Okay. Dr. Reaki, a friend of mine, thank you for coming, Rebecca. It's very crucial your support as a board member of ISCVS and leading specialist. Jacques is gathering with us. Thank you, Jacques. So we have to start in order to be on time. This is very important for all the organization. Professor Nikov, please join us as a moderator. And thank you once again for coming. And I'm giving you Rebecca.
Thank you very much, Ivo, because we are here for you, definitely. And I'm happy to present you, by the way, with the Tandem Carotid lesions, what and when to do.
Thank you, Rebecca. And thank you, everybody, for coming. Hopefully you will enjoy the multidisciplinary spirit of this meeting. And this is very important, collaboration and multidisciplinary. I'm trying to change the slides, but unfortunately, okay, my disclosures, nothing special regarding this topic. As a definition, by definition, the tandem lesions consist of a high-grade stenosis or occlusion of the extracranial internal carotid combined with thrombotic, in the most of the cases, lesion of the middle cerebral artery in the context of stroke. So this is the tandem lesion that occurs in approximately 15 to 20% of all large vessel occlusions on the brain. Definitely it's a challenge. The procedure is more complex, no doubt, because the carotid stenosis, in fact, is making more difficult the access to the target lesion for the stroke itself. And there are many studies during the years, absolutely controversial. I will show you how controversial they can be. For example, in the same year, 2018, there were published two relatively big series of patients with tandem lesions. This publication by Coelho have shown in 780 patients that there is no benefit from emergency stenting of the carotid lesion, the proximal one, and lower incidence of good flow, more than TC2B flow in patients with stents during the acute intervention for the stroke. So the same year in Jacques, in cardiovascular intervention, there was a very big meta-analysis showing just the opposite. That from the four strategies that are listed, cervical carotid stenting with double antiplatelet, cervical carotid stenting without antithrombotics in order to prevent bleeding, obviously, cervical carotid angioplasty only, balloon angioplasty with the risk of recoil and restenosis, and thrombectomy only of the distal lesion. So from all these strategies, exactly the opposite conclusion and the opposite result in this big group of patients. In fact, the cervical carotid stenting with full antithrombotic treatment was the best one. Recanalization rate, you see, that is in fact the huge p-value significance, huge statistical significance in favor of stenting, and also huge significance in good clinical outcome at the third month. So controversial is all the field. This is the result of the graphic result of this article. And definitely there is, during the years, there are many advancements of the technology. I would like to ask the guys to help me from time to time because the change of the slides is not very easy from here. Unfortunately, we have to fix that. Okay, this is the safety of emergent carotid stenting after thrombolysis, a multi-center matched analysis with, again, very good result showing something very important, that the preliminary intravenous thrombolysis doesn't at all changes the good results of stenting of the carotid, and together with the endovascular thrombospiration of the thrombus from the culprit lesion of the big brain vessel. Faruqi have shown again that carotid artery stenting group compared to the non-carotid artery stenting group has better flow, TC2B score better, and better clinical outcome again compared to the conservative group. So the carotid stenting was associated with increased successful revascularization and favorable functional outcomes on the 3 months, that in fact it's confirming the results that I have shown from Jacques intervention. Okay, what about the time? Anterograde or retrograde? So finishing the procedure to stent the carotid or starting the thrombospiration to stent the carotid? It depends on many details, but definitely when we have a critical stenosis on the carotid level, it's not possible to reach the large vessel occlusion, thrombotic occlusion to treat the stroke. Obviously, in these cases, we have at least to have a good balloon predilation before going, or even stenting in order to have good stabilization of the balloon catheter during the procedure. What about, what are the reasons for to have tandem occlusions? They are different, of course, atherosclerosis. One peculiar but not so rare reason, especially in women, is the dissection. So the spontaneous or traumatic dissection is possible to be one of the reasons to have tandem lesions of the carotid and the intercerebral vessel in one and the same time. And of course, in some cases, cardioembolism. I'm showing such a case. Dissection, 43-year female with dizziness and disturbance in balance and gait, a loss of speech after a car crash accident. This is the most typical scenario for carotid dissection. And the CT revealed bilateral dissection with total occlusion of the left and subtotal occlusion on 2 levels of the right. You see there is a stenosis on the level of the bulb and practically full occlusion distal just before the bifurcation of the middle cerebral artery. So in this case, we stented the internal carotid, and in fact the so-called pseudo T occlusion disappeared. Obviously it was a matter of flow and not matter of real thrombosis. And this is the result, MRI after 1 month. You see that there is a full restoration of bilateral, full restoration of the flow and the size of the vessels. The second case is definitely even more, let's say, not controversial, but very challenging, with multiple coronary artery disease, and in the setting of latecomer patients with stroke with right side hemiparesis. He came beyond 24 hours with proven preserved penumbra on the CT, so definitely we have shown with the MRI perfusion that there is potentially salvageable territory. And you see this is a critical stenosis of the left carotid artery and distal occlusion. So you see there is no flow upstairs. This is only the external carotid. The internal carotid is practically occluded, and there is some restoration of the flow very distally. So it's a critical stenosis of the carotid and practically total occlusion distally. So this is the after the implantation of the stent and double filter, the classic filter, the spider, and also the secondary filter. In order, this is the triple coaxial system from Contego Medical, giving us the much more confidence about protecting the brain. And this is the final injection with full TC3, in fact, restoration of the flow, not only on the level of the carotid, but also on the intercerebral level, with very, very good result. And there are many trials, ongoing trials with this topic. And in conclusion, I would say that emergent extracranial stenting is a promising approach for patients with large vessel stenosis or dissection. Mechanical thrombectomy should not be withheld because of a proximal carotid lesion. And acute stenting is becoming the standard of care over angioplasty alone in such cases. And thank you very much for your attention.
Thank you. And now we have Jacques Busquet with us, and very interesting topic, SAC management during and after EVAR.
Ladies and gentlemen, SAC management is not something easy. It needs surveillance, it needs a good team, multidisciplinary team, and let us see the options, challenges, and outcome. Just a word on my mentors. I am a cardiac surgeon by training with Francis Fontan, very well known for the cardiac congenital, tricuspid atresia, and univentricular heart. So I start with congenital, and then I moved to endovascular because it was so innovative that I went immediately to see my second mentor, Edward Dietrich. He was in Phoenix. AAA, it's a current concern that remains essential due to the risk of rupture. There will several options for visualization, and now there is also 3D algorithm who could help the surgeon or the interventional radiologist. Everybody in this room remember this person, Joan Parodi. He invented for the second time the EVA, endovascular exclusion of AAA, as early as 1991. It was published, but an Ukrainian went first. His name was Vodolos. We met him in Phoenix once. I died. My introduction is very simple. EVA is a minimally treatment for AAA. The goal is simple: prevent rupture. The issue and the risk is the SAC may still enlarge and going possibly to a rupture. In this case, you see the start at 50 on the left, upper left, 56, then 57 after treatment, then 65, and then 78. So this arrangement could put the patient at risk. You admit that. So what to do? This is the importance of the SAC management. You have to expect something, a shrinkage over time. If you don't shrink, there is probably something wrong. So shrink is the key of success. Complication could be a persistent endoleak, so you have to be very aware of the verification of the follow-up and for SAC expansion, as we told before. And the key monitoring tool is a serial imaging, CTA, duplex, sometimes arteriography, but it's not commonly admitted. Everybody of you knows the classification of endoleak. Just a word on type 2, it's very frequent, a retrograde SAC re-injection via the inferior mesenteric artery. We can embolize either before or after, and sometimes with a clip or embolization. Which are the intraoperative options? So, as we told, preventive embolization for the mesenteric or lumbar, direct SAC embolization, the global SAC that you embolize with particles, and maybe sometime you can use endo-anchor. That's anchor going into the wall, fixing the graft. There is something new in the field that a sponge-like design of shape memory polymer product. This is inflating with blood and making something solid, invading the sac. This is under experimentation, and they are going very fast in to put this on the market. So in fact, this is a remodeling of the triple SAC to improve SAC regression after EVA. So, which are, in summary, the post-operative management strategy, CTA, CTA follow-up, angio-CTA, if there is a good creatinine level, 1 month, 6 months, 12 months, then annually. You can delay with SAC embolization, onyx or coal, or you have some time to go to surgery, do open, and you open the SAC for very difficult case. This is a surgical conversion given by Dr. Netio. And sometimes you have some seroma, you have some fluid. This is what we call sometimes endotension. Which are the complications and pitfall? Non-target embolization is not sometimes your fault. This is the fault of the radiologist. Or you can have the radiation exposure that you have. You must be aware of it for your patient, especially your personal, especially feminine, and you. You can have a reperfusion via unknown collateral, and you can have a rupture if you don't follow up. This is for the youngest of you, the youngest generation. Some literature review, Van Schek, Tchaikov, Sidlov. I choose some Russian, some people from the East for you, East country. In conclusion, ladies and gentlemen, the SAC management is crucial for long-term EVAR success. Not all endolics need intervention, but you have to monitor the SAC size. What the future? It's a risk stratification with artificial intelligence and some advanced embolic particles that you can get from the market. Thank you very much, ladies and gentlemen.
Thank you, Dr. Jacques. I don't know if anybody has any questions. Well, I think it's very important. I don't know, I come from Mexico, so our population is not so often to go to the doctor, you know. And when they have this kind of lesions in the aortic, some of them, I don't know in France, but some of them, they don't have money for continuous tomography. So it's very often that we have ultrasounds in our office. So, Dr. Jacques, I have a question for you. In France, do they make the measure of the SAC only by tomography, or it's more often by ultrasonography?
Personally, I like very much to work with the angiologist and the ultrasound guy because it's a very simple technique. Sometimes you can add bubble, the bubble. Sorry.
The contrast enhanced.
Yeah, yes.
Yes.
Contrast enhance with bubble, and it's very important. You can find some endolics that you can find on the CT. Second, if you do a CT, you have to wait for the final phase, the venous phase, very late. You have to ask your radiologist to do it. And third, I would like to remind that in France we are very lucky. Since 1946, General de Gaulle, il institute in France the social security. The care in France, even if you are homeless or very rich, you don't pay for care. Some fees for the surgeon, a little. But we are lucky, so it's very easy to control our patient with AAA. Thank you, Rebecca. And by the way, I would like to say a word on Rebecca. She's a very talented surgeon. She's a woman, which is quite rare in the field. I had the opportunity to meet you in New York in our little group of 50 people. We are only the two foreigners, Mexico and France.
Yes.
We fight very much in soccer, but that's another story. And I'm very pleased to be with you today. Thank you, Rebecca.
Thank you, Jacques.
Yes, about the endovascular treatment of the AAA, I think the most important thing is to follow the SAC diameters. Many times we have endoleaks and regression despite endoleaks, and many times the opposite, no visible endoleak but enlargement of the SAC, and then we need treatment anyway. So probably this is also my practice to, first of all, to follow the patients with echography for SAC enlargement, and if we detect, then we proceed with more complicated studies.
Yes. By the way, in Mexico, we have a social security too, but unfortunately, where I live, in my city, there is no one vascular surgeon working at the social security hospitals, not anymore since this year. So it's kind of difficult for the patients to have a good, follow-up, first of all.
Can we ask the people if in Bulgaria, do you have social security in Bulgaria? Who pay for the care, the public or the people? Monsieur, can you name you and your city?
I'm your co-faculty, Dobrin Vasilev. Nice to meet you. So in Bulgaria, we have complete social security coverage, and we regularly follow our patients with CT. As Professor Nicole said, practically we don't have any problem to follow the at least in our center, but I think this is in general in the country. There is no problem to follow patients with CT. the most important question is what to do when we see the SAC enlargement and there is no visible endoleak. And maybe the word is not correct, visible, but what to do when the endoleak could not be identified. Because this is a problem at the moment. I don't know, Professor Nikov, what do you think about that?
I'm happy we don't have so much cases like this. I had maybe two similar cases, and in both of them we actually found source of type 2 endoleak and did embolization, and this worked. But sometimes really it could be just endotension, and conversion could be needed.
What do you think about these new embolization devices which we have now with the big coils of penumbra, what Professor Busquet demonstrated, or using some alternative foams for the embolization of the sac?
Probably this is a good solution for prophylactic embolization of the sac, and but there are not so much studies about this.
Thank you very much, gentlemen. We have to go.
Yeah.
Yes, we see you in 30 minutes, I guess. Let me see.
There is coffee break.
Yes, this is a coffee break, and then we are going to start with a live case. Yes.
Coffee break?
Yes.
How long?
30 minutes.
One coffee per person.